everyone. We've got about 2 minutes until we start. We just wanted to hop on and let you know that we're going to begin shortly. Hopefully everybody in attendance can see the panelists, see the PowerPoint. I see we still have a few people logging on. Okay, I have 12 noon Eastern Standard Time, so we're going to go ahead and get started. Hello, everyone, and thanks for tuning in to the New Norm Town Hall, brought to you by Midway Education and Catapult Education. My name is Samantha Wendell, and I'll be moderating today's Town Hall. We have 3 expert dentists with us who will be answering pressing questions from the dental community. We have Dr. Lou Graham, Dr. Karson Caprenter, and Dr. Ron Kaminer. I'd like to take a moment before we begin to honor those working on the front lines today, saving lives in hospitals and those essential workers keeping the lights on and the grocery store stocked. I'll be asking a series of questions that have been submitted prior to today's session. I'll be directing specific questions to specific panelists based on their expertise. We also may have some commentary as the discussion develops. Panelists will have a total of 2 to 3 minutes for their answers, and questions submitted during this webinar in the question box, which you will see in your control panel, those questions will be addressed at future town hall meetings. You can also email your questions to education@midwaydental.com. Let's begin with the first question. So the first question, let me get my screen here. The first question was submitted by Susanna, and I'm going to give this to Dr. Kaminer. The question is, what protocol should we follow to prepare for the first day after COVID-19?
Well, Samantha, thank you for having me, first of all, and I hope everybody is safe. In talking to many people, Lou and I have had conversations about this topic extensively. I think whatever protocol anybody adopts today, it's about mitigation of risk. And when we talk about mitigation of risk, it's about mitigating risk for the patients, the staff, and ourselves. And there's going to be a series of suggestions that we'll talk about today, which might change depending on when you start practicing. But again, it'll all boil down to mitigating risk. So first and foremost, I think patients are going to have a questionnaire when they come to the office. Patients will have a questionnaire. They will wait in their car until they're called in our practice. So we'll have a personless waiting room for a while, so to speak. They'll have a questionnaire that's pre-prepared about COVID, about potential exposure. Do they have the disease, lost sense of smell and taste, things, directed questions. We're going to take a quick temperature. We will have on hand, if needed, antigen antibody tests. And there's a big question about them of how effective they are. But again, it's a screening tool for us. So it's like going into battle with something as opposed to nothing. And then we're going to make changes, of course, in the operatory prior to treatment, that things like our PPE or pre-procedural rinses, things like that, that we're going to adopt But the point is, and the goal is to mitigate risk. We can't eliminate risk, but we're going to do what we can do to mitigate risk. Lou or Karson, do you want to chime in here at all?
Go ahead, Karson.
Well, you know, definitely things are going to be different. I think really aggressive screening, as you're talking about, is the key. Although we can't identify all of them, it's not going to be like it was in the past where somebody had a sore throat. They said, look, we know you and your staff wear masks. We decide to come in anyway, and maybe we'd see those patients. That's going to change. Any symptoms of respiratory disease, any temperature, they're going to have to be reappointed. That's really the key thing, and we're going to have to train our staff on all of this.
And I think how I would add to this is if you go to midway.edu.com, we've already come up with great screening questions. I see going over screening both written, visual, meaning teledentistry or verbal. I think you have to go over the questions again the day before. Their history could have changed. That's first. Secondly, I think everybody should go on YouTube and see the videos on how to put on PPE. There are specific ways to put on PPE. So go on YouTube, and it's about 10 minutes. It's done by nurses. There are many of them. And it shows you how to put it on and how to take them off. I think you should go to your office, at least if you're just starting out, at least a half an hour to an hour ahead of time, making sure you go over everything meticulously. I think you should be scheduling your patients differently. I think we're going to be doing pre-rinses or pre-brushing. We had Tanya Dunlap on with pre-brushing with Perio Protect, or obviously a hydrogen peroxide rinse. I think all of these things really come into play. I think you just have to have a battle plan. I know we're limited on time. We'll get to the next question.
All right, thank you very much for all of your input. We're actually going to move on. The next question is going to Dr. Carpenter. This question was submitted by Heather, and the question is, what are thoughts on PPE, including something to cover your hair in general dentistry?
Well, you know, it's a good question, and I will tell you that the guidelines and the guidance is changing all the time. But one thing we need to keep in mind, in the ADA's latest statement on this, they said we need to exercise what's called professional judgment. So it's based on the patients, it's based on the community we're in. But as I see it, I feel that we should be using head covers, you know, disposable head covers, changing between patients. I feel that we should be using disposable gowns on the patient and on the staff, change between patients. And I will tell you that, again, I'm speaking now of these interim period and this, what I'll call phase 1 period, is we phase into treatment. I'm not saying we're going to have to do that forever, but I'm saying right now, I think hair cover is a great idea. I think N95s are a great idea. I think disposable gowns are a great idea, as are shoe covers. Any thoughts on that, gentlemen?
I'll just say, Karson, I absolutely would do all of those. I would absolutely be covering shoes. I'd be definitely everything you're talking about. I think the issue will be is going forth is when I'm wearing, for example, my gown, what kind of gown do I slip over my gown that should be inexpensive if I have to go in and check an exam or do anything like this? Because we could be almost double gowning, Karson, as I look at it. Obviously, double masking when N95s are appropriate. And we'll get to N95s, but absolutely, I just feel even though we don't know how much contamination is via clothing, I still think why not protect ourselves to the max?
Totally agree with you guys. No need to pursue. We can keep going.
All right, thank you. This next question that we are going to be addressing is submitted from Melanie, or sorry, this next question is from Lynn, and this question is for Dr. Carpenter. So Dr. Carpenter, would you please, give your opinion about, will anything change in regard to using nitrous on patients?
Well, to me, there won't be great changes, but let me state this, Samantha. First of all, I like to do anything that can create less potential exposure. I certainly would prefer to not use nitrous. I certainly am not going to encourage people to use it because it's one more thing to clean. Now, if you're going to use nitrous, to me, absolutely a disposable nose piece is a must. That being said, I don't have any problem with people using nitrous. Our protocol isn't really going to change. Very careful cleaning and disinfection, throwing away the disposable nose piece. I don't see any big changes. I mean, there's a lot of people, they need that. They rely on that to be able to tolerate dentistry.
So for years,
Thoughts
we've
on
had,
that, gentlemen, that you have?
yeah, so for years, we've had personalized nose pieces. So in other words, patients had it, it was assigned to them. And if they were not just patient, we'd store them and they'd come back. So we would cavicide those or glutaraldehyde those and disinfect those. I think that where it's going to get tricky a little bit, and like Karson, I'm not going to encourage it. I won't tell somebody no, but I'm not going to say, hey, do you want nitrous today? Because it is going to be a little more of a pain in the neck for us. I think the question that comes into play, what Lynn might be even referring to, is what about airborne pathogens that have been exhaled in the hoses? And that becomes a little bit of the risk. I'd venture to say that many offices do not take their hoses off and immerse them in glutaraldehyde after every patient. I'd like to think we're supposed to do that, and we do, but I'd venture to say that many do not. They may spray the outsides down, they may spray the rims down, but not taking them off and immersing it. And I think if there's going to be some sort of a change, hoses will have to come off, so you'll need extra set of hoses, multiple sets of hoses, and you'll have to actually submerge or immerse them in glutaraldehyde. And what that's going to mean also is anything, of course, that you're doing that to is going to break down faster, and you're going to have to raise fees in conjunction with nitrous because all these things are going to cause breakdown of parts and rubber hoses sooner. So I think that's where we could see a change.
Thank you, Dr. Kaminer. Dr. Graham, do you have any thoughts on this?
No, I really got to agree with both of them. And I love the idea of what are we going to do with the hoses? Absolutely. And I think our procedures are going to be longer because when we come in, I'm going to want to do more on these patients. So, and I'm a big nitrous guy. So I am absolutely very interested in how we can be as conservative as we can with these airborne pathogens in these hoses. So good points. Yeah.
You know, one last thing I want to mention is we're going to want to contact the manufacturer of those hoses. Probably most of us don't have instructions for use on how to disinfect those. We're going to have to find out what the appropriate way is depending on our manufacturer.
And to that point, I believe Midway, via my discussions with Ryan, have already started on that pathway for their customers. They will be updated on specifically that, Karson, from the manufacturers. Yeah.
It's good to hear.
Yeah, good to hear. Okay.
Excellent. All right, we're going to move on to the next question. The next question is for Dr. Kaminer, and this is submitted by Melanie. The question is, how are we going to reduce aerosol spray and keep us and our staff protected from COVID?
The $64,000 question that I think we all want to know and want to answer. So again, mitigating risk. In dentistry, we cannot eliminate aerosol spray. So how are we going to mitigate this risk? I think one way is pre-procedural rinses. So I think it's been shown that the virus lives in saliva, potentially on the tongue, as well as the cheeks of our inner cheeks. So one of the ways that we can mitigate risk, and I think, Samantha, we lost your video camera, but one way we can mitigate risk, I believe, is pre-procedural rinses, like Lou said. Hydrogen peroxide, 50-50 with water, 30 seconds to a minute, or a minute and a half of pre-procedural rinse. So that's going to mitigate what's coming out of the mouth as being horrible. Next step, rubber dam. I know it sucks, but rubber dam. You may not be able to do it for every patient. Rubber dam is an option. For hygiene, going back to more hand scaling and getting away from cavitrons and piezo, or using high-speed evacuation, or Lou and I were talking about a product today, potentially, that Dentsply has, that has the dental mirror and suction on one end, and I'm blanking on the name of the product, and using the piezo or cavitron in limited use in the other hand on the hygiene side. I think those are all ways to mitigate risk. My big concern that I see is if you look on Facebook and you look at the groups and you look at everybody advocating these share side big mouth suctions that I used to have in the office years ago when we did air abrasion. And my concern is that they might work, but I want to bring into light the fact most of these units have filters. In talking to a few scientists in the last couple of days in looking for the right solution, those filters, when the unit is turned off, are a harbor source for bacteria and viruses. And the big question becomes is, who's going to change the filter? I know staff's not going to want to do it. I know I'm not going to want to do it. And even if you do change the filter, where's it going to go? Is it going to go in a red bag? Are you now going to seal that red bag right away if it's a third full? All these things come into play. So rubber dam, pre-procedural rinses, high-speed evacuation, all these things are going to help. And people aren't going to want to hear it. We're going to have risk going forward. It was always there. We just didn't know about it. This was there in January and December. We just didn't know about it. Now we know about it. Guys, feel free to add.
You know, I guess the one thing I'll say is I'm really going to be an increased fan of any device that connects to an HVE. Like, for example, a brand that comes to mind is like an Isolite type of situation. I think that anything that can decrease aerosols, I mean, as you said, Ron, we're never going to eliminate aerosols. We're just not going to. And one thing I want to throw out, I'll mention probably several times during this, is I want to talk some doctors off the legs because they're really scared this is the way they're going to have to practice forever. It's going to get better. Remember, you know, some things will change permanently, but we're going to be able to do productive dentistry again. It's going to take some time. We're talking about things we need to do now during the interim period and things in the phase 1. Hopefully, as we get to phase 2 and 3, it'll get a little simpler.
So I agree, Karson. I think, you know, this is a temporary new norm, but I still think, and it's going to go back, how do we eliminate aerosol? The concern of aerosol is a COVID patient walking into your office. If you screen and test, you will minimize the chances of a COVID patient coming into your office, which will minimize the concern over aerosol. And there's no doubt about it. We will have aerosol, we will. And from the rubber dams to the isolites, there's no question. When I look at hygiene, I look at a system like Perio Protect, Ron, that if patients come in and we actually take impressions on them, they actually wear these trays, and these are not even going to be traditional Perio Protect trays. Hygienists would be able then to bring the patients back in 2 weeks, and that tartar will literally just flake right off, and they can then do hand scaling initially. And I think pre-procedurally, how we minimize, especially ultrasonics, Karson, because ultrasonics show far more dispersal than even high-speed handpieces. So I think there are ways to minimize aerosol containment. And I think ultimately there will be some kind of filtration systems coming into the market via Midway and others that we're just going to have to look at, and even in a high-risk room, how we will put patients who are higher risk or COVID, let's say post they've had it, and they have an acute emergency. I mean, those will be our uber high-risk patients. So I think we may have one operatory dedicated to them. I do see all these happening, at least near term for now. Yeah.
Oh, you're right. You're right, for sure.
So I just want to add one more point to this because I think it's important.
Okay.
I just want to add one more quick point. One of the things that's happening today, and it's very sensitive to me because today, in my office and in my home, is I've done a little bit of research here, and we're installing a product, and you can Google it yourselves and check it out, called the Aerus Air Scrubber, A-E-R-U-S Air Scrubber. It goes into your HVAC line in your office. It's relatively inexpensive. I think my install with buying it is about $1,500. It was co-developed with NASA, so it's got the NASA label on it. And basically what this device does is it intakes the air in your office into your HVAC, it treats it with the UV and a photocatalyst and spits out hydroxyl ions into the air. At a study done at the University of Cincinnati, this product has shown to kill 100% of virus and bacteria in 24 hours. Now, I'm not saying COVID, they didn't study COVID, but they studied a slew of bacteria, H1N1, swine flu, avian flu is all studied in there. You get an 80% kill in 20 minutes. Is it a perfect solution? No. Is it an adjunct to everything we're doing? Will we have better air in the office? Yes. Will our staff appreciate it? Definitely. And will our patients appreciate it? For sure. So for the $1,500 cost, it's not a big investment. One unit will cover about 3,000 square foot of office. So not a bad concept. Look that up. I have no vested interest in this, the company or anything. I want to make it clear. It's just me doing research.
And to that point, Samantha, let me just say, so I've been on the phone and had meetings with Novartis through Midway, and I absolutely think that there are ways that we can really protect ourselves from the aerosol issues. And like this company that's based out of Ireland, again, state of the art, and it kills the virus. Like Ron's, we've got to kill the virus, not worry about filtering and everything else like that. So I think there are solutions that we can be doing, no doubt about it.
Yeah, I agree. Dr. Kaminer, you're actually the second person today that I've heard that installed a device like that in their house. So that's or going to be, which I think is fantastic. I think that is, again, the new norm of this pandemic. So, with that, we're actually, we're going to move on to some more questions. And I know that we'll have an opportunity to come back to this conversation when it comes to air purification, because we do have a question later in the panel that we can talk about that. The next question is submitted by Mary Jo, and this question I'm going to give to Dr. Carpenter. It's something that we've talked about a little bit already about the new norm, but the question is, what will be the new norm PPE protocol for hygienists? N95s, are hygienists going to be required to wear N95s? We've kind of already talked about the disposable gowns, hair covers, shoe covers, but if you could touch on that, that would be fantastic.
I will. I'll be glad to, Samantha. Now, I have to say that anything any of us comment on here regarding this, we're just trying to extrapolate based on what we see now. I mean, there's new guidance being released all the time, so things may change. I'm going to tell you that once we get out of our society the sources of this bacteria, the reservoirs of disease, if you will, things are going to change. But I think that the normal for now during the interim period, then during even the phase one, as we start to go back to regular practice, is going to be N95s for hygienists. Now, if everybody here has ever worn an N95, I have. It's not the most fun thing to wear because you feel like you're drawing air through it. It's restricted. But I'm going to tell you that long-term in your career, I don't think you're going to have to wear N95s. I do think, though, that now you need to, probably for the foreseeable future, I'm talking 2, 3, 4 months, you're going to have to until we get these reservoirs of disease out of our society. That being said, don't forget the best thing, better than filtering it with an N95, is getting it at the source. Those are the things we've already talked about: high volume, careful screening of patients. But yes, you're going to be wearing N95s for the foreseeable future, in my opinion.
Okay, thank you. And I know,
Samantha, let me ask you this. Karson, since we're on the spot, and it's always good to do this, if we're working in a non-aerosol procedure, recommended to still wear N95s? What are your thoughts?
My thoughts are, if you're not generating an aerosol, so you're doing an exam, you're greeting a patient, you're doing perioc charting, anything where you're not running the high speed, the low speed, or the air-water syringe, I'm very comfortable wearing a level 3 mask. I'm very comfortable with that. The second I'm going to generate an aerosol, an N95 at this time anyway, would be what I would suggest. And in fact, the ADA in their most recent guidance even said when you can, wear the best protection available, that being an N95 or a KN95, which are basically equivalent.
Thank you, Dr. Carpenter. Now, to add to that, would you recommend wearing an N95 under a face shield?
Yes, I would, absolutely. The best thing about a face shield, a couple of good things about it. One thing, it protects your N95 from moisture, because unless you have a surgical N95, and by the way, the difference is a surgical N95, that means it's a combined fluid-resistant mask and a N95 respirator. Unless you have a surgical grade N95, you need protection from moisture. One of the best ways to do that is a face shield. So I highly recommend face shields.
So Samantha, I want to just chime in one thing here if I can. Since Lou knows that I'm very much a contrarian in a lot of ways, I'm going to throw a little bit of contrary in here. I think what Karson is saying is ideal. But realistically, many of us are going back to work now, some states, 2 weeks, 3 weeks, and the availability of N95 is going to be scarce. And I'd be very concerned to send a message to my hygienists out there that you can't go to work unless you have an N95. Because if there's work and there's not masks, what are we going to do? So what I then would say is a level 3. So let's look at filtration of N95 to a level 3. They're very, very close, right? It's a lot of it depends on the fit and a couple of extra things. I would have 2 level 3s. I would tape one to my face, have one over it, and then use a face shield if those are readily available. Because my gut is between now and September, the availability of N95s is going to be slim. And if they're available, they may be so costly that it may not be realistic in most procedures. At $10 a mask or $8.50 a mask, if they're not going to reuse them, even if you can get them, these masks don't come in boxes of 100. You know, they come in boxes of 20 or 25 or whatnot. I don't believe there's going to be a plethora of boxes of N95 masks for every hygienist in the country to utilize in 2 weeks, because the hospitals, in theory, still are having some trouble getting them. In theory, who knows if that's true or not? But in theory, the point is, I would be comfortable with myself, and if myself with my hygienist, with a level 3 and a face shield, or a level 3 taped to my face and a face shield.
So
thank you for that, Dr. Kaminer. Dr. Graham?
The best part about this is we can openly disagree, which is great. I look at it, I think the hygienist needs it even more than the dentist. If they're using any ultrasonics, I think they've got to have an N95 mask. And I think the way we're going to go forward, and this is why Midway has sent out surveys so we can allocate PPE, is you may have to have a mask last honestly, days. And we're going to be double masking, you know, a level 1 or a level 2 over the N95. But openly, I think if you can get a mask, we should all be able to get enough masks to last us a week. We're seeing emergency patients only now. If Ron's talking elective dentistry, which I get, is hygiene technically, in a sense. I do think we still are going to have to wear N95s, masks over those, and hygiene and facial shields, just because we got to be so protective. Now, I can only say that's right now, but that aerosol, Ron, it just concerns me. I hear you with taping, but I'm just too concerned. I think a mask, one N95 mask, can almost go a week the way you're, you know, cleaning your masks and everything else. I think we'd be okay. We just hope we can get them. That's to your point. I hear you.
Yeah, and I mean, right now there is a huge demand, and the supply is the issue. So I appreciate all of your thoughts on that. And with that, we're going to move on to the next question so we can get through these questions. And I do know that there is, we can come back to this because there are questions about reusing N95, sanitizing N95, masks over N95. So we can touch back on that once we get to the question. This next question is actually for Dr. Kaminer. This was submitted by Deborah. And the question is advice on treating pediatric patients in this new norm, considering these pediatric patients may be carrying the virus without displaying any symptoms. You know, how would testing fit into a pediatric dental practice? What are your thoughts on that, Dr. Kaminer?
So I'm not a pediatric dentist, but we do treat a lot of kids. One of the things we decided, and this is going to be tricky right off the bat, is no one makes it past the front desk except my patient. That means mommy can't go back with a child, siblings can't go back with a child. We can't have an audience in the room. Now, if the child is really not behaving, we'll let a mother back. But I want to limit exposure to my team and to the patient itself. You know, we're going to have to do a lot of screening when it comes to kids. Have they been sick? Are they sneezing? Are they coughing? It's not going to be so easy to finger stick, a kid. But I think what our initial thoughts are, is that, and remember, these antibody antigen tests are not perfect. Depending where you read, between 50 and 90% accuracy for antigen and antibody. But what I think we're going to do is one day prior to the pediatric appointment, the parent will come to the office and pick up a test, do the finger stick at home. Hey, I don't want blood in my office. I don't want the child screaming in my office, and show us the result of the test. I believe that's what we're going to do, especially if we have any questions. I mean, think about it. Once in a while, we see a child that has a swelling on a tooth and they spike a fever. How are we going to differentiate between those kids and COVID? So we're going to have to do real thorough screening. Has anybody in the family been exposed? Parents been exposed? All those kind of things. And again, it's about mitigation of risk. Or you could just do what Lou does, say I don't treat kids, and be done with it. Guys, anything?
Well, let's face it, that's a big concern. Kids are definitely able to transmit disease, but rarely display symptoms. So that's an area of big concern in a practice. It's something I'm concerned about. And I like your idea, Ron. I think that we need to know the status of those kids. Just because they're not displaying symptoms doesn't mean they can't affect us. So it's. And I'm sure we're going to, again, be receiving even more guidance on this from CDC over the next couple of weeks.
But, and add to your point, Karson and Ron, you have to know what's going on in those homes. And that's the screening questions. And I'm not going to be comfortable having my associate, because you're right, Ron, I won't see them. I won't see the little boogers. But openly, I'm not going to feel comfortable having a kid in the office unless I know what's going on at home through screening. And if the home's been clean, isolating, social distancing, yeah, I'll be comfortable, Karson. But if I'm unclear, unless it's a true dental emergency, we're going to have to make sure that we know how to handle that via screening. Yeah. Yep.
All right. Thank you guys for that. Moving on to the next question. And this is a question, we're back to the mask. Here comes the mask question. David wanted to know, and this is for Dr. Carpenter, and again, Dr. Kaminer, Dr. Graham, feel free to weigh in on this, but, one mask per patient or one mask per day? And with the cost of KN95, there is definitely some, room for negotiation here, right?
Well, you're right. And let me just state a couple things. I mean, first of all, I want to say, I actually am a real dentist. I actually practice dentistry, so I'm not just somebody in an ivory tower. That being said, I've been involved with more OSHA inspections in dentistry than anybody in the United States. And I don't want to see anybody get into trouble. And one thing we have to be careful of is what I call off-label use of things. One thing to keep in mind, what's the difference between a mask and a respirator? A KN or an N95 is truly a respirator. The difference is a respirator is designed to protect us, the user, whereas a mask, when you really think about it, a mask, a surgical mask, a procedural mask, is really designed to protect the patient from us. Okay, the difference being, well, the filtration material in a mask may be excellent. For example, a level 3 mask filters out 98% of a bacteria aerosol of 3 microns or say 0.3 microns or larger. But the problem is a seal. The seal on a mask to protect us is not good, whereas the seal on a respirator is good. It's designed to protect us. So my feeling is, and again, I know everybody has questions about N95s and masks, don't they? So I don't think we're overdoing this. Remember, if you want to protect you and your staff, that's a respirator. If you want to protect the patient, that's a mask. I'm just concerned, I don't want doctors to get into trouble with off-label use of these things. Now, that said, if I can only get enough N95 respirators when we start in a couple weeks to have one person use one, each person in my staff use one per day, we're going to write down the difficulty we're having, we're going to document it, and we're going to then cover that respirator with a level 3 mask. We'll change the mask between patients. We'll use the respirator all day. But to me, that's even a little off-label. Technically, that's supposed to be a disposable device. I don't believe anybody's going to get into trouble if they have a reasonable protocol like that. They've attempted to get them. They can't get them. They're still protecting their staff, and they have a clean technique because they're covering that. In an ideal world, if I can get enough, I'm going to spend the money and I'm going to use an N95 on each patient. I don't want to get into off-label use. That's my caution to all my colleagues out there.
Thank you, Dr. Carpenter. Dr. Kaminer or Dr. Graham, do you have anything to add to that? Would you like to move, or would you guys like to move on to the next question?
I agree with them 100%.
Me too.
Okay, excellent. All right, well, thank you. Let's move on to the next question, and that is, again, for Dr. Carpenter. Dr. Carpenter, what do you think it'll be mandatory to use the HVE for all procedures that create aerosols, including the use of ultrasonics? And I'm going to just pipe in here as a hygienist, thinking of the ergonomics of using a HVE while using an ultrasonic. That's going to be very challenging day in, day out using that. What are your thoughts on using the HVE with procedures that create aerosols, especially in hygiene?
Well, my thought on it is this. I mean, we all remember back in dental school when we would hold a HVE tip in the left hand and a handpiece in the right. That's not very practical. It's not very ergonomic. To me, again, as we said earlier, nobody's going to insist that this be done. As the ADA says, quote, you need to use professional judgment. To me, that would mean that in an aerosol generating procedure, you attempt to use high volume. Again, I like, for a hygienist, a high volume connected device, something that they don't have to hold with their left hand. Will it be mandatory? Will there actually be a law that says you must use this? No, but it's clearly best practices. That's what I think hygienists should be doing when they're generating an aerosol.
Thank you. Dr. Graham, Dr. Graham or Dr. Kaminer, either of you have anything to add?
So I'm not going to disagree with Karson, but I'm going to say I think hygienists are going to have to use high-speed HVE. They're going to have to. And I think with what Dentsply as company one is launching, I love it. What do hygienists hold as a hygienist, Samantha? What are they holding in their two hands? The ultrasonic and a mirror. That's what they're holding, and the low-speed suctions in the right corner of the mouth or the left. What Dentsply is coming up with, which I think is brilliant, is you're holding a high-speed vac with a special tube, and it's got a mirror on it. So you won't need to hold a mirror. You'll be able to be basically suctioning using the mirror and now doing your ultrasonics. And again, if we can minimize ultrasonics by using other methods, then I think it'll be less exhausting and you'll be still diminishing aerosol. So I think what we're going to see are companies coming out with products with answers to our current dilemmas. And I think the Dentsply product could be one such product for hygienists. That's my thought.
That's a really good point.
I agree with Lou here. That product from Dentsply is called PureVac. I was showing it to Lou this morning, and I have to do more investigation, but I totally think, and again, it looked inexpensive enough that you can easily outfit multiple hygiene operatories. So I don't, the question is interesting, will it be mandatory? It may not be mandatory, but I think every hygienist will want to minimize aerosol any way they can. And even if it creates some procedural dysfunction for her or him, meaning used to a saliva ejector. So they'll have a saliva ejector and they'll have some sort of a high-speed evacuation, whether it's PureVac or something else. And they're ultrasonic and they'll have this combined, or as Karson said earlier, a dry shield or an isolite or anything else that that will work. I think hygienists will want to do it.
Yeah,
and
I agree.
Will want to work for the doctors who provide that too. They'll appreciate that the workplace is being made safer.
So wait, Samantha, I got to ask Karson a question because this is what I do on the new norm. So Karson, here's my thought on this, like this new product from Dentsply. I think if we can minimize aerosols in general, it's a really good thing. So I think we're going to be adapting new products and new habits that even when this COVID crisis or pandemic is over, I think we're still going to be using some of these because we should be minimalizing these aerosols and cross contaminations. What do you think?
Oh, I think you're absolutely right. I think this is what OSHA loves and calls, because I'm the OSHA guy. OSHA calls engineering controls. Okay, and engineering controls aren't necessarily mandated. For example, maybe in Ron's office he has an instrument washer. Maybe in your office, your engineering control is an ultrasonic bath. You're both right. Well, in the same way, you're right. These things are going to stick. Who wouldn't, even when COVID is out of our society, who wouldn't want to breathe less aerosols? I think you're right. That's going to stick.
Yeah, and I also think it's based on the design, because Ron's office, which I've been to in New York, he's got a lot of closed operatories with, it's just like mine's wide open. And so the aerosol thing is a much more challenging thing in wide open offices. I just couldn't afford walls at the time. Yeah.
Thank you guys very much for all that. I wanted to continue moving on so that way we can get through majority of these questions. This next question is actually for you, Dr. Graham. It's submitted by Phil, and he wants to know, how can I keep my staff safe and feeling confident when we begin to see patients? And I know you touched a little bit on it when you guys were talking about the reducing the aerosols, but I'd love to hear a little bit more about that.
So it's very interesting because the number one thing my team gets is that I don't want to do anything without safety. And we were not going to jump in and see emergency patients unless we had a protocol. So Karson and Tracy really helped me develop our protocols. My hygienist Gwen helped me develop them. And I think staying safe means we had to educate ourselves on the problem, not meaning just COVID's a problem, but educate ourselves on what's the problem and how do we want to address it. And as I go over screening questions with my front team, and they have to understand this, it really the safety starts before the patient ever walks in, and then the doctors are deciding on whom to test. I think once they walk into the office, our protocol has to be, how do we minimize cross-infection? And again, from Tracy and Karson and our protocols of rinsing and all the things, I think that's how we instill safety. And with my patients, let me also say what I did, and I highly recommend. What we did was, I did a video My wife just shot a 2-minute video while I was talking to my patients about their safety is most important with ours. That video, what we did was we sent a cross email and text to all of our 2,600 patients through Weave, and through Weave, it allowed us to send a link. And I love that for Weave and many other reasons, but now the patients could link on and see my video telling them what our new protocols would be, why we were testing, our screening questions. All that makes my team feel safer and my patients. I think we all have to do that. I just do.
Thank you very much, Dr. Graham. I apologize, my slideshow I hit something and it's just moving like it has a mind of its own. Dr. Kaminer or Dr. Carpenter, did either of you have anything to add to Dr. Graham?
Yeah,
what he had mentioned about?
Yeah, I just want to say one thing. I think that part of keeping your staff safe is starting now. What I mean by that is we have a WhatsApp group with our team. I communicate with them 1 to 2 times a week. There is so much misinformation out there. So, and I know we've been studying this stuff a little more and maybe can scrutinize it a little better than some. So the first thing I'm doing is trying to dispel any misinformation. I remind them that while this is different, we've always practiced in a risky profession. Hepatitis, HIV, people not disclosing, not telling you, yeah, this is different, but we've always had risks. So one of the things that we do is we have an open dialogue now, explaining what we're going to do when we come back, telling them, like Lou said, we want a safe environment, installing the air purifier and the HVAC, making it safer, anything that we can do to make them feel more comfortable. Because at the end of the day, they have 2 options, right? Continue coming to work or not coming to work out of fear. And I don't think, and while we have this risk in dentistry, that fear just, that risk exists in the supermarket, at a wedding, in church, in a synagogue. I mean, yeah, it's higher in dentistry, but it exists everywhere. So we can live in fear or live smartly in a way that will allow us to be safer. So a lot of this communication, giving them that virtual hug, telling them that, hey, it's going to be okay. There's going to be a transition period. And I'm a big believer that most of us have this elastic short-term memory, and we'll be going back to normal in the not so distant future. I'm not saying in a month or 2, but this is not lasting forever, especially once we have a treatment or once there's a reputable vaccine. All these things are going to be bye-bye.
Very true. Very true. I'm actually going to move on to another question here. And obviously my mouse seems to, my PowerPoint wants to just have a mind of its own. But this is a great question. You had touched a little bit, actually you touched a good amount on this. And so I wanted to come back to this, Dr. Kaminer, about the air filtration. So Anthony asked the question, should every office have a HEPA air filtration system? Plasma, advice? I mean, what are your thoughts on that?
So I think I've said a couple of times what we've done in the office. We've put something in the HVAC. I think everyone should do their research. There are a number of things you have to look at when it comes to filtration. Realize that COVID is somewhere around 0.1 or 0.2 microns. Many of the filtration systems that are being sold will claim they can only filter up to 0.3 microns. So are we actually solving the COVID problem or not? So a key opinion leader posted something on Facebook, like an advertorial the other day, with the owner of a company advertising a unit. And he said, I'm putting these in all the operatories. When I went on the website of the unit, it says it only filters 0.3 microns. Well, that's good, but it doesn't, if COVID's 0.1, in theory, it's not solving the problem. So I think that's one thing to look at. The second thing, anything that's got a filter, according to a scientist I spoke to in the last 10 days, when that unit is off, that filter is a reservoir for bacteria and viruses. That doesn't mean it doesn't leach back out. So that's a problem. The other thing is, like I said earlier, who's going to clean that filter? The minute you open that filter to clean, whether it's a week, a month, 3 months, or dispose of it, something's being leached back out, potentially. So all these things have questions. Ideally, if I was going to put a filter like that in, I'd want something that had a UV or a plasma that's treating the bacteria, that could kill the bacteria. Do I think it could be overkill? Yes, and I would tell people just something like this, be smart. Midway's got plenty of options, and if you're going to do it, they'll be ahead of the game and tell you, hey, you should or shouldn't. But I'd be concerned being reactionary to outfit 7 or 8 operatories with a $3,500 filtration unit. There's maintenance on these things. There's a lot of potential questions. Would a system in the HVAC be smart? Ain't perfect, but you definitely will have better air. So that's why I went that route. I am not saying that I'm right. This is based on my research. Listen, people are talking about putting in negative pressure rooms. I saw someone today talking about that. $8,000 to $10,000 per room to do in offices. Is that realistic if you're treating a lot of high-risk patients? I guess it's possible if you're an oral surgeon and you're going to do that. Is that realistic for most general dental offices like Lou or mine or others that have many operatories and ripping apart your office? I'm not so sure that's realistic, in my opinion. But those are the options I think we have. Gentlemen, feel free here. This is a very interesting and controversial topic.
Go ahead, Lou. You answer first, and no. Okay, well, I'll give you my opinion on it. I really, first of all, if you wanted a so-called clean air machine and you had one before, that's fine. But if you're going to go and spend a lot of money to do that, thinking that it's going to take care of a problem with COVID, you're wrong, because in my opinion, because don't forget, first of all, COVID, well, it's about 0.12 microns. As I always say, it doesn't travel alone. It travels in a form of droplet nuclei, which tend to average 3 to 5 microns in size, because otherwise it would scare you. When you read an N95 mask, it says it filters out particles larger than 0.3 microns. Well, if COVID is 0.12, it's not going to filter it, but they tend to travel in droplet nuclei that quickly fall to the floor. So really, I like Ron's idea. I would tend to spend my money on something that's simpler. For example, the heating and cooling system. You talk to your HVAC person, they can maybe put in a bigger blower, take your typical air exchanges per hour, that's about 6, 7 air exchanges per hour, maybe up it to 10 or 12, like a surgical facility would have. Put a better filtration system on it, maybe a HEPA filter, maybe something that treats it. But I hate to see all of my colleagues out there spending big money, $3 grand in operatory, to do something that's unproven and maybe not necessary. That's my thought.
Karson, to what you just said, besides putting the ARIS units today, we upped our thermostats today to have a circulation mode on there that can be adjusted with an app on the phone. So I can adjust when I'm not in the office on the weekends. I can have circulation going on in times where I want the fan off, maybe not to waste electricity. I can circulate the air. So anyone who has an older thermostat, newer thermostats with a circulation mode will also improve some airflow when you're not in the office.
It's a great idea. You know what? Even if you have an old-fashioned one during working hours, flip that switch to on rather than auto, so your fan's running the whole time, and you'll have much better quality air. Simple, reasonably priced things we can do to make the office safer.
Dr. Graham, did you have anything to add to that? Dr. Carpenter or Dr. Kaminer's comments? Okay.
Well done.
All right. Well, we have time for one more question, and we're going to switch gears a little bit and talk about this question here on the screen. So from John, he submitted a question. Would you clear the schedule out for a certain period of time, 1 to 2 weeks, to triage and appoint those most in need? And I'm going to give this question to Dr. Kaminer, and again, Dr. Carpenter and Dr. Graham, feel free to comment or add to.
So I think this is extremely practice dependent. I know in my situation, it's not possible. I was booked out 3 weeks prior to this. We're presently booked out the entire month of June. So, and that's with appointments the way we scheduled before. That's going to have to be adjusted. As Lou said earlier, one of the things we didn't touch on, but we'll touch upon it here, is maybe changing the logistics of our appointments. So if someone had a treatment plan with a crown on 3 and a crown on 19 and then a crown on 14, inlay on 29 and a DO on 28 and a disalingual on 9, and you might have broken that up into 3 or 4 or 5 appointments. What you might do if someone you know is negative, block out 2.5, 3 hours, or in Lou's case, 7 hours, and block out enough time to get all your prepping aerosol done in one appointment. You know, and that's where I think could change. The other thing that I think could change is in-office milling of crowns and printing. I think will become way more prevalent now, because if I can get all that work done in one appointment as opposed to bringing them back, I think that becomes interesting. So speaking to Ryan or the Midway reps about a simple to implement in-office milling system with design right now could be a logical spend of money at this point. I also think if you can't do that, having an arrangement with your laboratory to say, hey, I'll pay a little more money, I need crowns back in 24 hours. If I scan it before 1 o'clock, I want it back tomorrow by 2 or 3 o'clock. So I can minimize the length of time. Because even if you're testing, and let's assume the test is accurate, which we don't know if it is, you're only as good as when you took a test. So if you test them today and insert in 10 days, you have a 10-day window of exposure. But if you prep today and insert tomorrow, you're mitigating that risk once again. So clearing the schedule out, I think, would be difficult, because I have people, even now, my associates in the office today with 6 emergencies of fractured teeth or broken teeth and pain. So those people are going to need crowns when we get back, but I already have a full schedule of patients. So I don't know if that's going to be realistic in my practice. In a smaller one doctor practice, maybe.
So,
Thank you, Dr. Kaminer. Dr. Graham or Dr. Carpenter, do you have anything to add?
Go ahead with that, Lou.
yes, given the limited time after Ron's verbiage, I would say, Ron, not all of us can prep a full arch in 11 minutes. I get it. I really do. I will say this. You are going to be thinking differently. So when Ron and I were talking milling in office, I currently don't mill. I do everything digital and send it out. I think we will be milling more in the office because, again, saving on PPE, bringing the patient back. Ron brings up a good point, which is shocking, but he does bring up a good point. If we end up doing, let's say, 1 day crown and bridge, 1 day, what I would envision then is we will be changing our scheduling, meaning we may do our crown and bridge procedures in the morning, send the scans out or the impressions by pickup service, and be delivering them the next afternoon. You wouldn't do that. You wouldn't start a prep in the afternoon and get your results back the next day. So we could be doing more crown and bridge or more implant dentistry, whatever, in the morning, and more direct restorative in the afternoon. That's one thing. I think when I go back to work, like Ron, my schedule is booked easily a couple weeks, probably more, but whatever. I think we're going to go back and we're going to have to do definitive work on our emergency patients first, because we've been kind of holding them together. So I do think it'll be emergency patients first. I think our procedures are going to take longer. We're going to have to be changing our scheduling. And honestly, like we've been talking, this is your chance to get the heck out of PPOs and only keep maybe 1 or 2 in your office. Because unless PPOs step up with better fees and PPE fees, it's just not going to be worth it. And I think that's going to be a priority when you start seeing patients, because it's all about cash flow. I know it sounds terrible, but we've all been unemployed for a month. And I know Ron feels the same way. Karson?
No, I agree. In my office, things are not going to change that much. We always try to keep some open slots for emergencies. And obviously, we already have people who, for example, are awaiting crown deliveries. They're going to be the first. They're on deck. They're going to be the first up. But in general, we're not going to make big changes in the way we schedule, other than we are going to have to create more time. An hour appointment now is probably going to be an hour and a half. A half an hour is an hour. I mean, just because of the precautions we're going to take during this interim and phase 1 period. But again, guys, gals, it's going to go back to somewhat normal eventually. We just have to be patient.
Yep.
Agreed.
All right. Well, that brings us to, we've got about 2 minutes before 1 o'clock. So I'm actually going to close it up. And I just want to say thank you to everyone for participating, attendees, as well as panelists today in this week's town hall. And I want to say thank you to Dr. Carpenter, Dr. Kaminer, and Dr. Graham for coming on today and sharing your expertise, sharing your experiences, as well as thoughts on this pandemic and how we're going to move forward in the dental profession and practicing with this pandemic. I know that there were a lot of questions that were not addressed today. So if you've submitted them, continue to submit them to Midway Education. We'll monitor our inbox, and we will host future town hall meetings to address questions, especially questions we didn't get to today and those questions that come into the inbox. If you haven't already, we do encourage you to tune into the latest episode on the new norm, where our CEO, Stephen Kizzy, discusses supply chain. I watched it this morning. It was really insightful to just hear about supply and demand and, what we're going through with PPE and such. We appreciate your support of Midway Education, and until next time, we wish you the best health, stay healthy, and you guys have a great rest of the week. Thank you so much.
Thank you.
Thank you. See you next time.